Welcome all to join our second day's program of the Taiwan Biological Therapy. And I believe that after the first day yesterday, there's a very great live cases and discussions, and all of us really feel we are getting a lot. So today we still have a live cases and several. I think it's a wonderful talks for us. And in the first section, I'm the moderator. I'm Dr. Jocelyn Lin. I'm the cardiovascular surgeon from Xinguang Hospital, Taipei, and our distinguished international faculty, Dr. Ida. Ida would like to say something to everyone. Yeah.
So good morning, everyone. I'm Osamu Ida from Osaka, Japan. So I'm an interventional cardiologist. I enjoy very much for the live demonstration and the case presentation.
Yeah.
Thank you.
And also we have several the expert panelists. So would you please introduce yourself from Dr. Zhong?
Hi, I'm Dr. Zhong from Taiwan Xinguang Hospital. Also, I'm an interventional cardiologist.
Dr. Zhu?
I'm Song Yichu from Chang'an Memorial Hospital, Linkou. I'm intervention radiologist.
Dr. Koi?
Hi, I'm Sonyoung Choi from Seoul, Korea. I'm interventional radiologist.
Good morning,
Okay.
everyone. I'm Guomin Tan from Hong Kong. I'm an interventional cardiologist.
Dr. Anita?
Good morning. I'm Christine Anita. I'm interventional cardiologist from Indonesia.
Good morning. I'm Dr. Vila. I'm a vascular surgeon from Thailand.
Hi, I'm Dr. Kong, and interventional cardiologist from Taiwan.
Thank you all. And is it how is it right now in the operating room? Sorry.导播，我们可以有画面吗？
隔壁是已经开始了。
Okay. The first case, I think it's just a common femoral artery lesions. I think the is for atherectomy procedures. I think it's a quite controversial topics of these cases.
这边还是
And Dr. Kui, I see you on the screen. Can you hear me?
Hello.
Yes. Yes, we hear you.
Yeah. This is Dong Che from Severance Hospital, Korea, and it's my great honor to be here at Jianggu Memorial Hospital with Dr. Jie.
Yeah,
Sorry, and with Dr. Lin. Yeah.
Okay, thank you.
Today we prepare very interesting case and case presentation, please.
Yeah. Can you show a slide of case 1?
Yeah, case slide. Yeah, okay.
This is a 65-year-old man, and he presented with left here poor healing wound with infection, and now is ongoing osteomyelitis and undergoing antibiotic treatment now. And his underlying disease is hypertension, type 2, diabetes, or the ischemic stroke, and history of left triple vessel disease post bypass surgery, but due to heart failure progression and SVG2-PTA restenosis, we do a PCI less than months. And the left picture shows the initial left SFA diffuse P2 diffuse disease in this July. And we do the scoring balloon and the drug coating balloon angioplasty. And last month we recheck due to a poor hearing wound and the residual calcified stenosis at a distal SFA is our target because previous scoring balloon cannot well dilate this lesion. And the next slide. Next. It's a Belloni vessel. We had done the angioplasty for a Belloni angiotibial and the posterior tibial artery last month, and we just check a pitch. Angio is still patent, so right picture is our target today. Any comment or?
Yeah. And this case is critical ischemia, wound in the left hip and also osteomyelitis, and long history of diabetes mellitus. And Dr. Shea already did a very nice treatment with left side artery, left common iliac, and also SFA and below the knee artery. But mid portion of SFA still residual stenosis and heavy calcification. This case is not common femoral artery case, mid portion of SFA. So patient wound does not healing, and also osteomyelitis is slightly improved, but still infection is ongoing. So today our target is mid SFA, heavy calcified region. So I will show today's angio. Yeah, today's angio first, please. Dr. Shea already checked the previous treatment.
Can we see angio
change
now?
the angio.
Can we see angio now?
Okay.
The proximal SFA, and here the distal SFA, our target region.
You can see the target region on the dilation, and looks heavy calcification.
Yeah. Previously, there is also a critical stenosis at a P2 segment, just above the aneurysmal dilated portion. But we do scoring balloon at DCB, and the result is fine. The Belloni portion. Yeah, so okay, yeah, it's the angio today.
So any comment or suggestion?
It looks like the distal SFA lesion still, but the proximal SFA, at the ostium, it looks still quite stenotic. So it is not a target
Proximal.
today.
Yes. Yeah, proximal. You mean the SFA ostium? We did not check the pressure gradient, but
There's
we
no
already
gradient.
treated recently with the scoring balloon. So I think there is not today's target. Today's target is the middle to distal here critical stenosis.
Okay.
Because this is the undilatable portion at the previous angioplasty, and so our main target will maybe be here, and then the IVUS.
At that time, we used this. Dr. Shea used the special balloon, but does not dilate it. So today we
So Professor
try-
Choi, so this is Osamu Ida speaking. So I think the
Nice to meet
posterior
you.
tibial artery, yeah, I think the posterior tibial artery has a next one, previous
Oh,
one,
yeah, this one.
and this one.
Yeah. This one, yeah.
Some defect was found in the posterior tibial artery because
Oh.
TAP should be the posterior tibial artery for acquiring the beta wound healing. So maybe we should check the posterior tibial artery because you use the IVUS. For I want to see the severity of the posterior tibial osteo. And also, I agree with your
Okay.
opinion for treating the middle part of SFA using the Foquan. But I think that I'm curious about the distal embolization. So, which location is best for the placing the EPD, embolytic protection device?
Yes. So we discussed about that. So we just apply the spider distal protection
Not yet.
device.
Not
And,
yet.
I think the best portion is the artery is 6 millimeter by check the IVUS. So I think the best portion is the initiation of the popliteal artery. Yeah, so where is the
So because wire is advancing for posterior tibial artery, I want to see the severity of the calcification the posterior tibial artery.
Okay, and we also check the IVUS the distal SFA, but not the posterior tibial artery. So we'll check the IVUS. I play first. Yeah.
Can everyone see the IVUS on the screen?
No.
Oh.
Screen is yeah. Okay.
Okay, so this is Opticos 18 system. The IVUS is pulled back from the popliteal artery. From here, the size of popliteal are around 6.4 millimeter. There is some calcification, but not serious. And if you pull back here, you can see some nodule calcification protruding from the sister clot. I think this is the lesions, the middle and the SFA. The stenosis starts from here. Now we can see here is circumferential calcification. And around 1 o'clock to 7 o'clock, there's a deep calcification.
Okay.
And then the proximal size is 7.4 millimeter.
Okay. So, Osamu recommended the posterior tibial artery check. So,
yeah, I can pass.
And this is live
for Austrian.
Can we record it now?
Yeah.
Okay,
We can
start recording.
Yeah.
This is mid portion of the posterior tibial artery.
So, Doctor, so can I see the simultaneous angio, please? So we can see the IVUS only.
Oh, yeah.
Okay. Okay, thank you.
Angio and okay, yeah. Let's start again.
It is not easy, but you can see the IVUS and still posterior tibial artery and going to ostium of posterior tibial artery.
Maybe here the pocket. like the past religion.
So, Dr. Choi, how do you think about the indication for revascularization as a posterior tibial artery? Because I think the flow is very nice. So we should concentrate
Yes.
that for treating the middle part of SFA.
Okay.
And we should concentrate for preventing the distal embolization during the Fork 1 treatment.
Yeah, I read your opinion. So today, I'd like to focus the Fork 1 treatment of distal SFA, and after that, check the posterior tibial artery finally, and we will decide. But I've showed some stenosis and plaque in posterior tibial artery ostium, but flow is not good. So I want to only focus on distal SFA target lesion.
So here is some recall after angioplasty due to the calcification. Maybe after treating the SFA, so we should carefully check the time course of the wound. If the delay in the healing was observed, so we should treat this portion using the rotablator or something.
Yeah.
But anyway, thank you very much for your effort.
Okay. Let's start. Yeah.
Is there any comments from our panelists?
I still have hi, Professor Choi. I have one question. From the initial angiography, I can see some stenosis of the ostium of the SFA, proximal SFA. Can you show us the IWAS for the degree of the stenosis of the proximal SFA?
Can I hear us?
Initially, we didn't do the IVAS of the OsteoSFA.
Or later?
Yeah, we didn't check yet, but after Fork 1 treatment, we want to check the ostium also. Yeah. Okay.
Okay, please continue. That we just shifted to the operating room 2.
Okay.
We'll come back to you later.
要不要吗？没有，放心买。
Hi, Dr. Wu, we see you.
Hi, hello.
Yes.
I can see.
So, can you have a briefing of this case?
Yeah. Please. This is 53 years female. She has that is a compression. That's that's dented many years ago, and right now he have post-thrombotic syndrome with leg edema, so he hopes to the recurrence of the iliac vein.
So this patient have a DVT history. So right now we are treating the PTS.
Yes. And right now the wires go through the previous scan and try attempt to the inferior vena cava. And Dr. Wu tried to snare the wire from the right side of the vein. 用帮我照那个，一个帮我照，对。好像外面，是外面，看上面。确定。应该在外面。外面吗？照着。
导播，我们看一下那个荧幕好吗 ？OK。Dr. Yan。
嗨。
Yeah.
不是那，看看，拿回去。President Lee, welcome.
So the previous stent has been occluded. Yeah.
Yes,
that
previous
okay?
stage is total code.
用那个 Wishmaster。
And I ever try handover also to do it before. Why I failed to include the way to the previous step. So today I hope the Professor Wu can have the patience.
Actually, you can see the imagery. This case, most difficult is what you see is all collateral. It's not the true. And even you find you see that the upstream straight, it's not reach the stem. It's just parallel the stem. And another branch you also cannot reach the stem. So the first task is how to identify the entry point. It's very, very difficult. But fortunately, I found there is a small opening by the wire. So I penetrate and reach nearby the stem. So you can see the previous angel. Yeah,
Dr. Wu, could you tell
Hi,
us that today the SSI is still at the growing?
Still female, yeah. This is female.
And
because I use echo, I found that their CFVs remain preserved. So I decided puncture the CFV. I think the old corrector, even corrector, will reach to the CSV. If I can recharacterize the CFV to the IVC and I can make a decompression, so the patient symptom may be helpful. Okay.
So the initial
If I can
angiogram
find
that can
the total occlusion, you can see. I will show you that.
I know that, or can you show us that the initial angiogram at from the femoral? Is it the distal? Is a common femoral vein, or is it?
Yeah, sure. Wait a minute.
Because we would like to know that is that any reason for this stent occluded.
Yeah, this is a PA view.
Okay.
And you can see two lateral view. You can see that the corrector goes straight up. It's not the right puncture, the right external iliac, and there's a big corrector with a big turn. Okay. That is not also. We have another angle. Thank you. You see? And as we know, there's not reasonable for the iliac to be such a torturous. So I think it's not good point. You see that the wire I stay there. There's a small hole. So I try to puncture that. And can finally find a way to the orifice or stent. You see that? Thank you. Good. Why 没有？这个不是，这跳。没有了嘛，没有录到。So unless I find it's very close to the stent, so I try to introduce the wire. And at first I use V18, and I cut the stop part. And after penetration, now I almost reached the orifice, but the orifice still outside the stent. Yeah. So now I have the finest way to penetrate. Okay.
Right, Dr. Wu, this is Guang Ming from Hong Kong. The very challenging case.
Hi.
Hi.
Yeah, very challenging.
Good morning. Very challenging case.
Morning.
I see you already have biplane cine. Would you want to check the biplane cine to make sure that the wire is
actually this is a single plane.
I see.
This is a single plane.
Right.
We only have single plane.
Right
now. Yeah.
I'm Sonyoung Che from South Korea.
Yeah.
What do you think about the cone beam CT? We can guide.
beam.
Yeah.
We don't. You want cone beam CT? Actually, we don't. Right now, we don't have cone beam CT.
See that you have a snare on the contralateral side. Is that your plan to get the wire in the IVC and then snare and externalize it?
Yes, yeah, because I can't pass any smaller balloon, so I think snare and the through is a good way to advance the balloon.
I think the challenge. Okay. And what wire are you using?
V18.
It's V18. I see. Right.
It's a V18, only V18.
And the
I think here is the. All this all submitting now.
Another view to make sure the wire is still in the stand.
Yeah, in the stand. Actually, I'm not confirmed, but with the two direction, I think it's in the central. So this might be in the lumen. I have two ways. One is past the CSI.
Yeah,
and then
just check with one tester. Yeah.
But it's not easy to pass even CSI or the smaller two balloon. I sometimes will push the wire to the heart. If you see the heart, I think it might be the true lumen, right?
That looks true, yes.
Yeah, you see the right? Yeah, that look like true, right? So at this time, I will try to balloon angioplasty. For this case, I think the most important is the strategy after passing the wire. Passing the wire sometimes not very difficult, or sometimes difficult. But after passing the wire, you do balloon angioplasty, and then next. What is the next for the instant occlusion with the venous stent? Sometimes venous stent occlusion by because the intimal hyperplasia and sometimes mixed with thrombus, and even you do balloon angioplasty, what's the next? Till now, some interventionalists will put another stent. But it seems not make reasonable, right? And DCB for this case, this situation seems no data right now. And in the vessel with intimal hyperplasia and thrombosis, DCB is good for the patient. I still didn't understand that. Another way, I say yes, sir.
No.
Okay.
Please.
That is slow motion. So it means that you will use the IVUS to check the actual.
Yeah. I'm sure I will use IVUS, but right now even the 2O balloon cannot pass. So
okay.
Yeah, I will do the balloon angioplasty, then check the IVUS and show you all, and then we see what the next step. My plan is to do the balloon dilatation to enough size, and then maybe consider DCB or Viabahn. I think Viabahn is another choice.
Yeah, I think
because even cover stain is occluded, we can easily recanalize in this situation.
Is there any comments from our panelists?
And I think the other issue is you have to clarify the reason why the stent is occluded. Maybe it's the inflow problem. Maybe it's the compliance of TNT calculation. Yeah, so you might actually need another stent distally to cover up the inflow as well.
Yeah. Good.
Because just now we see a lot of collaterals from the inflow. So the competition of the flow with the stent flow must be very much. So unless you cover the some collateral as well to redirect the flow into the stents, or any stents later on will surely occlude it again.
Yeah, but before put stent, we will check the IVUS all the way from the street, and you all can see that what's next. I think that's the better way. Okay. Anyway, but for this case, we have to pass the wire first, right?
Yeah, that's right.
It's very test, very test. Okay.
Dr. Wu, that it seems that the CSI is also very difficult to pass. This is why because it's not all the way in a stent. It means
I'm not sure. Actually, I'm not sure. So maybe it's through maybe somewhere where I penetrate the stent and outside the stent.
That's right. That's right.
That's right. So I will use the 4M40 balloon and check, and then check the IVUS.
Okay, please.
Yeah, I have to create a channel for IVUS to penetrate. Yeah.
The CSI should be easy.
先拿出来，先拿出来称一遍，先拿出来称一遍。嗯。OK， 好，这个吧。14。他10了，我们只有12。我退了。对啊。因为他这4.0反正4.0上面。So I see the 2O balloon can pass. So then we'll change it to the 4.0 balloon. According to Dr. Zhang Jiaxiu, yesterday's comment, I think the case maybe not no need to treat, right? Yeah, but how can you identify the venous hypertension? I think it's very important issue.
Mm-hmm.
跟他讲一下我的痛脚，请他讲一下。是，看看。去哪儿？啊，这样的。
So how long is this stent occlusion?
How long?
I mean the chronicity of.
Not sure.
If it's a very chronic occlusion, then I think a lot of the material inside is a very dense hyperplasia and also chronic organized thrombus. In those cases, I think probably additional stent might be needed just to get the adequate lumen gain at that stent ISR area.
Yeah, totally agree. But what kind of stent will you use in this condition?
I don't think there's any evidence to suggest one stent is better than the others. There's a risk with cover stent as well because cover stent, if the patient is not compliant to anticoagulation, the stent thrombosis rate is actually higher than bare metal stent because of the lack of endothelialization. But at the same time, it has a benefit of slowing down the ingrowth of the new intima or the into the stent. So it's you have to take a risk of a stent thrombosis if you put a cover stent.
What do you think about the DCB in these cases?
I don't think
I
don't think in venous there's any data on DCB because I think the pathology of a venous ISR is quite different from arterial, because from arterial, a lot of the time it's neointimal hyperplasia and neoatherosclerosis. But for venous, most of the time the RSR come actually from thrombosis, kind of like a subacute thrombosis. So in this case, especially, I suspect that was previously because of the poor inflow that causes stagnancy in the stent and thrombosis. In those cases, really optimizing the inflow would be the key to prevent the stent from thrombosing again.
Yeah. So we check IVUS first, right? So I put IVUS, 018 IVUS first, and check the lumen is in, the lumen is in, the Y is in the true lumen.
Dr. Wu, are you using the 3.5 or the 1.8 IVUS? It's a 1.8, all right.
Okay, this is what is IVC? Cool. And the proximal stent is still patent, right? And here is occlusion. All occluded. I think I'm in the stent, in the center of the stent, right? You see that? Yeah, I remain in the stent. Yeah, now here's so the Y is all in the stent, right? So the next step, maybe I will dilate.
Yeah, but at the very start, at the starting of the very proximal site, I think part of it is subintimal.
Yeah, you should check it out.
Yes. Yes, and we also find some membrane between the venous and the stent. So proximal.
So before the stent, I'm outside, right? So I have to recanalize. Yeah.
Yes, some membrane between the.
Yes. Okay. 这我们把那个地方看出来是哪里？等一下。啊。I understand.
Yeah.
So I puncture from outside the stent, go to the stent at the beginning.
Oh, Doctor, would you consider that from the other side, read bidirectional?
Yeah, actually, bidirectional is another choice, but the supporting system is quite difficult. You know, even from neck or from the contralateral, we don't have good support to penetrate the occlusion like this.
Yeah.
So, but fortunately, I already penetrate the stent, right? So I dilate the full stent, and then I can go from the other side, and maybe I can recanalize the proximal part.
Okay.
先把上面撑开，然后我们前面比较沉，然后再把那个，看不清楚了这个，你这多少人？多少把人？好了，好了，撑开吧。
So Doctor, please continue. That we'll come back to you later.
Yeah, thank you.
Okay.
Thank you. Okay. 撑开吧。我在室内是入门内，撑开吧。
导播到 room 1, please.
요거. 네. 그다음에 요거 이렇게 세 개를 아니면 두 개를 보여줄 수 있는 사이드 바이 사이드로. 사이드 바이 사이드. 제일 처음에 시작한
하고 이거를 두 개를. 可能就是有一个对比，第一个是做 procedure 认的 IVUS， 下面是做 procedure IVUS， 可以做一个对比的这样的影像吗？可以吗？这个画面呢，上面是放之前的
우리한테 넘어가 사이드 바이 사이드.
사이즈가
It's a room one that we have seen.
做完之后的 Iris。
Doctor,
Okay. Yeah.
would you tell us then right now?
Angel, please. Yeah. Okay. I will show you. Now I will say, Angel, please.
Yeah. Change to the Angel screen.
之前的 Iris 就是之前录的 Iris， 对，做完之后的 Iris 可以。
No.
没办法。
From the filter.
Okay. Yeah. We
所以录起来的
put
没办法。
the spider filter. You can see the spider filter at here.
Yep.
And we tried the hook one 2 times. And yeah, this is a hook one. Pretty and Angel.
Yeah, Angel.
This
Yeah,
is
after
yeah,
the first one.
first one.
First.
First one and
Okay.
okay. This is second time one and Angel.
Okay. Angel.
So hook one can cut completely, but I think the main classification cutting and we
And the video can see here. 这也可以是从开始
here.
can 可以秀这个地方。
Yeah, we can see the spaceman here.
Okay. To pick
Yeah, the first one had been lost.
Yeah.
The second
I
time.
sort of classified okay.
Whatever it is. So
why don't you check the Iris, please, Dr. J?
在3000。
I think we should check Iris. Yeah. This hospital is Jangun Memorial Kaohsiung Hospital, but this is first time for me, but the facility is very nice. And Dr. Che is very expert. So I'm very happy and very convenient to live in this hospital.
Okay.
Okay.
Yeah. Iris can start from here.
Iris.
OK， 开始了。好吧，那还是我们就先开始。对。OK。
Stop. This is the distal part of Iris. Yeah. Please.
刚开始after hook。可以real time看到 Angel 的那个影像吗？两边 Angel 加 Iris。对。
We are approaching the target area. You can see some cutting area.
So, Dr. Choi, what would be the endpoint you're looking after for Hawk? When would you stop and when would you do additional Hawk again based on the Iris and the Angel?
Okay. Okay, stop.
Stop?
Okay, yeah.
Okay. Okay. I think there is no clear criteria to stop Hawk one, and so it is very hard to answer. but usually Hook-Kwan then going through.
So,
and,
Dr. Choi?
but, not
Dr. Choi,
not straight. Yeah.
also I'm speaking. So I think you published an article comparing the IRIS and the non-IRIS for DCB treatment. Maybe the cutoff value of the MLA is really important to predict the restenosis. Maybe you can measure the MLA before and after Hook-Kwan.
Okay.
It might be very helpful.
Yes. Okay. And actually that measurement is after balloon angioplasty. Hook-Kwan is just cutting the calcification, not fully dilated the whole vessel. So I think the Hook-Kwan is not complete treatment.
Okay.
Yeah. So I think it's a plug modification. So after Hook-Kwan, after that kind of atherectomy device, right directional or rotational, we need balloon angioplasty, and after balloon angioplasty, we can decide the procedure, the stop or.
But you can capture some material after the atherectomy. So maybe that this patient does CLTI, and maybe I think that we will finish without complication.
Yes. I agree. Yeah. So I think how about this thing? Hook-Kwan, one more or the balloon angioplasty?
I think atherectomy improve through a region modification for scoring balloon or cutting scoring balloon maybe enough, but
Angel, please.
Or we also can try again if everyone thinks it's not so beautiful at this point.
Can you put the angiography on the screen?
Yes. Screen angel, please. Not IVUS.
Yeah.
Angel, last angel, please.
Yeah, angel. Oh yeah.
Okay. This is the last angel after Hook-Kwan. So I think we need balloon angioplasty.
Okay.
And which size?
Dr. Choi, Dr. Choi, I'm Dr. Vilan speaking. What kind of the balloon that you choose? You use a plain balloon, high pressure balloon, or scoring balloon, or cutting balloon?
Usually after this kind of after atherectomy, I usually use the NC balloon. Yeah, non-compliant balloon.
Oh yeah, okay. That's 6.
Yeah, 6. Yeah.
6，那6的我们现在有6AT 680还是什么的 NC 的，那他要 NC 的有什么对，就是 Achilles 还是那个什么比较，他是要 non-compliant 对，就有 Achilles 还是 Highlander 他们没有拿来 Achilles。我们那个 gauge 下吗？好，Iris 什么？又碰到。but it's not high position 没有6的呀。Highlander 有拿。610。it's only longer size for a non-compliant balloon. It's
semi-compliant is okay. Yeah.
Our Pacific is okay.
Yeah.
Okay.
But very long.
No, 80.
Yeah. Okay. Okay, let's go. Back.
Yeah. Yeah. Yes. Yeah. Yes, it just goes straight. Please. Yeah. Okay. Straight. I'm not sure if filter will be for the break. Okay. I hope. Okay. Inflate. Slow two. Still. 6. And
How high did you go, the pressure?
12.
12.
But patient complaint. Okay. 14. Patient complains some pain. Okay. Yeah. So, 14 is okay. Yeah. 12. Yeah, 12 now. There are some indentation, but patient complain pain, so I don't want more palpation. This is pressure is 12 right now. But still indentation.
Yeah, not open completely.
Yes. Yeah. 14. Light increase. 14 now. 14 now, but still indentation. Maybe it's not easy.
Yeah. Even you open it with a more higher pressure, that means that this lesion will recoil absolutely. So you're gonna hold again or consider to put any scaffold for the lesion.
Okay. Down. Keep 12. If I modified this plug completely and with any indentation, I think and after make a big dissection, I think put the stent is the one option, but if still not fully dilated and some calcification, I think the stent does not good function at that time. So any scaffold is not good this patient.
Any comments from panelists? Anyone?
Do you mean recoil after
any
deflate the
opinion?
hypertrophy? Okay, I have some case like this. Sometimes a combination between atherectomy and followed by scoring balloon and followed by DCB.
Yeah, it's okay.
I'm not sure for this case if the IVAS show some recoil, maybe additional scoring balloon and then followed by DCB. Maybe
so means that scoring balloon still work well on the calcified.
Yeah. Some cases it work well.
Yeah. Thank you for very good advice. Very good comment.
So, in your experience, what kind of scoring balloon? Is it like chocolate or?
No, only the normal scoring balloon. Angioscope scoring balloon.
Display. We balloon dilated over 3 minutes, so I think it
So, Dr. Choi, so
Is
I
enough
think
time?
you can measure the MLA after balancoplasty.
Okay.
If the MLA
Okay.
is around the 12, it's good enough for
Mhm.
good patency based on your
Yes.
literature.
Yeah. And you, please. Yeah. Okay.
The theater.
Oh, yeah. Sorry.
Here is the two bed. Oh, yeah, still there. Okay.
Yeah. Still okay. So,
Yes, still.
and your first and I was.
Okay. Yeah.
Yeah.
Oh.
Please. Yeah. Okay. I've.
Yeah, something inside the basket.
Okay. Right. Angel shoulder looks better, but still stenotic, and this balloon is over the wire balloon, that monorail system. So spider filter is slightly the tube, but you can see some debris at the spider. So I think the filter device is usually needed for this kind of atherectomy procedure. Okay, I'll start here.
Okay, start recording.
Ives, please.
Iris view.
No.
Dyson. Oh, yeah.
Okay, you can see Ives, right?
Yeah, we can see.
Yeah. Start. This is this SFA and the manual pullback.
导播还是回到 room one。
Yeah, we just passed this smallest area, and I think we should check the ostium of SFA.
Okay.
Yes, please.
She's may need to be back.
Yes, it's okay. I'll try.
Yeah, the ostium.
Yeah. Okay. This
Okay,
is
this is
ostium.
ostium.
Okay.
Let's start.
And please measure the area.
The MLA.
Yes, please. Ostium of SFA is not small. I think the ostium of SFA is okay, but area is still.
This is a great portion.
So
I think the MLA here is
yeah.
12.73.
So, but what I do?
I think the DCB, because MLA is
DCB.
greater than 12. This might be a good patency after DCB therapy. But main mechanism of the restenosis in this region is a recoil. Maybe we should have a cross follow-up after DCB therapy. But anyway, the MLA is much better than before HOC. So, and we can also capture some material in the filter. So we should finish only we should finish without complication. That's a very convenient strategy, I think. How about Dr. Choi?
Dr. Choi?
Yeah.
What do you think about DCB applying?
Yeah,
this
sure.
region?
I think by a previous angioplasty result, I think DCB is and can achieve good result for this patient. Yeah, so, and after this kind of atherectomy and the lumen size have been achieve better, bigger size, and will improve its distal runoff and tissue growth a lot, I think.
Okay. 6.
So yeah, 6.
Okay. Yeah.
DCB
，so
6有没有120的还是对6 by 120 6 by 120 DCB.
I will come back to you
It's
after the
overdrive,
DCB.
right?
Yeah.
So
And right now,
think
that's
we should
so we
use
invited
the
our
slide.
first speaker, Dr. Professor Li Renguang from National Taiwan University Hospital. You're going to talk about the treatment of the long calcified vein population cover stents.
Thank you, all my good friends. It's my great pleasure here to present my case. So today I'll talk about the tips and tricks in managing long calcified femoral popliteal lesion to cover more. And so after this all hard works, just like Dr. Joe and all the operators, the final thing is we need to complete our endovascular therapy. So we have a lot of things that currently we can use. We can use the DCB, DS, bare metal stent, woven stent, and of course the stent graft. So according to the guideline currently we have, not only from the ESC, but also from the ESVS, we know that currently the drug-based therapy is the class 1 indication, 2A indication that we can have, whether we can use the DCB or DS. So from this perspective, now we can use the DCB and the DS. So do we have any rooms for the bare metal stent in the woven stent and also the stent graft? But again, we know there are some cases for the DCB failure. From the presentation of Ida Sensei, that we know that if the lesion is the SFA osteo lesion or the CTO lesion, we have much more risk for the future restenosis or failure of the DCB. And of course, if we have more risk factor, is from 0, 1, 2, we got higher risk for the occlusion or restenosis. Not only from the DCB, but also we have the risk for the DS failure. Again, from Ida Sensei, we know that if there's plate burden more than 50%, just presented the MSA is less than 12, and if we put the stent over the P1 segment, the future risk again will be a failure in these cases. So after this scenario, the DCB and the DS may have the risk for failure. So what kind of scenario we can use for the bare metal stent in the woven stent and stent graft? Of course, for bare metal stent, if we see all the clinical trial in the real world data, we know that once the lesion is longer enough, you can see from the best SFA sport trial, you can see the bare out stent is about 50%. Of course, this bare out stent is bare metal stent, is the nitinol stent. So yes, we have the rooms for the nitinol stent. How about for the interwoven stent? Of course, if this is the calcified about the P1, P2, P3 area, we know that the Supera have better radial force In their clinical trial, they have 0 stem fracture, because if you see from the angio, it's like this. This is the superior stem, and this is the standard 19 stem. There will be a crush over the angle area. The last thing is, how about the stem graft? We know that in current strategy for the endovascular therapy, why we can do the endovascular therapy in this competition is from 5 centimeter to 25 centimeter, is from the ESC consensus. It's 5 times longer in these 20 years. Why the data is 25 centimeter? It comes from the registry and the study from Gold Viabang, because longer in general, the longer lesion, the patency rate will be less, but not for the cover stent, because the only issue for the cover stent is from the inflow and the outflow, the 2 edges. So in the past, we want to put the cover stent about so-called the normal to normal. We want to put the cover stent from the healthy side to the healthy side. But we know that most of the femoral popliteal lesion is all disease, And this trend is not compatible to the current guideline that we should put the drug-based therapy in our fem population. So how to treat this? Let me introduce my first cases. So this is a coronary total occlusion. It's more than 25 centimeter. And we pass the wire, try to advance a little. This is a Guardius MG to knuckle a little. And finally, still, there's a collector from the distal side here. Then the final pass, we try to retrograde to have the recanalization like this, because it is calcified. And then finally, this is the re-entry. We go to the balloon angioplasty for over all the vessel like this. After the aggressive balloon dilatation, it's like this. This is the initial angiogram. The ostium is patent, is distal. You can see a lot of dissection here. And then we need to choose our therapy. Of course, it is the drug-based therapy era. So if I can choose, of course, I want to treat with the DES. According to the study, that the DES have better potency for the coronary total occlusion. However, we need to know that the distal area here is the P1 area. So according to a study, we don't want to put a stent over here. So what to do next? In Taiwan, we only have stent, bare metal stent, interwoven stent, and stent graft reimbursed. So for the DCB and the DS, the patient need to pay extra pay for the DCB and the DS. The patient, the economic status is not good enough. They can only afford 2 DCB. They cannot even afford the DS. So for this patient, I finally try to put the cover stent. And the cover stent is not into the P1 area, and this is the collector inside. So after putting all the cover stent and even to the proximal part of the cover stent, and this is the final angio. Let me check. And this is the initial angiogram, and this is after balloon angioplasty. And this is to put the cover stent. And for the both sides of the edge, I use the DCB to cover this. So I do not need to jeopardize the collector of the distal portion. And of course, I can put a DCB to cover the ostium. So this is the first case. Of course, again, if the patient can afford more, I will put, my opinion, I will put the DS in the whole area, but the patient cannot afford that. For the second cases, it's a little complex. The left side is the non-contrast CT. This is a non-contrast CT. So a lot of calcification. And it looks like the iliac total occlusion and the fem-pop total occlusion from the ocean of the femoral artery and to the distal part. The distal part is similar to the previous one. There's collector inside here. So how to treat this patient? For the ACEs, it's quite difficult because it's from the very beginning of the common iliac artery. I don't have much support for this patient. So I need to, my opinion, if I don't want to treat with the brachial side, I want to treat from the distal retrograde. So I puncture the distal part and try to negotiate my wire retrogradely. I use the sheathless technique, and currently now this is the only access besides the right femoral. I advance my wire slowly because you can see a lot of calcification is over here. I pass the wire with the gladius, the Astato, the Harbor, the old wire I can have, I use it for this penetration. And the last part here is severe calcified. I rotate the table, try to advance, negotiate my wire. And then you can check here. This is my wire, and then you can hear the angel is the last row. Finally, the final one I can is only this part, and I check the angel a little here. But now I cannot advance my wire anymore. I cannot advance my wire anymore. So I try to do the externalization. So how to do the externalization? Because you can appreciate that it's severe calcified here, and I can do the wire here. So I try to puncture here. I try to do the externalization to pass the wire into the needle, but it is only a dream like that. So I cannot. And then I pass the microcatheter here again. I try to advance, but fail again. Finally, I put a 4 French sheaths, try to negotiate my wire into the 4 French sheaths, and I can do the pull and through technique to advance my wire. But again, it failed. So I checked angel. It seems that there's a row here, so I changed to a soft wire and pull bar this area and advance here. So why I pull bar this area? Because it is the iliac total occlusion. I don't have much support from here to use a sheathless wire. So I like to, after balloon angioplasty here, I want to puncture this area. After the balloon angioplasty, I puncture this area to advance my wire. Initially, I want to put a sheath over here to have a better support to do this one. But fortunately, you can appreciate that this wire just into the aorta. Then I try to do the snare because initially I don't have any support from contralateral side. But now I can do it from the right side. And this is the initial angel. You can appreciate that a lot of CTO here. But now, after the angioplasty first, this is the wire snare from here. And now we have the iliac flow like this. So then this wire is from the distal femoral and do externalization again. Now I have the all support from the distal part. This is the scoring balloon. I do all the scoring balloon for the distal part. And let me check. And this is the final angel. This patient, he can afford all the DS and the DCB, but what to do next? My opinion for this chronic total occlusion, iliac occlusion, heavy calcified CTO, my opinion is to choose the cover stain. So for the complex calcified long CTO, I use the cover stain. And to use the cover stain, I can of course also cover the initial puncture site here. And the final part, because here I can use the DES into the common femoral artery. The common femoral artery initial here there's a vessel. So the distal part stain graft, I use the DCB, and the angio is like this. And I here DES DCB, and this is the common femoral artery. Now we can have a relatively healthy common femoral artery. And finally, I put the cover stain to hold the iliac artery. So let me check. This is the initial angio, a lot of CTO and calcify. And after the bundle angioplasty and the cover stain, and all the manual I can have. And this is the final angio. And the proximal part, stain graft, DS, DCB. So this is another example. So this is a patient. This is a non-contrast CT. And all this vessel is totally occluded, heavy calcified. How to treat this? So this patient, I can use a DS, a cover stain, and then the DCB and the Supera with the DCB. And this is this patient now have been followed up in my clinics for 2 years. So in the past, we want to put the stain graft so-called normal to normal. Now we can change this idea to with the DCB or DS is the drug to drug. So this is my favorite like drama is the Super Sentai. However, it's a pity they are going to close in this after 50 years. What I want to say is that from this scenario, in treating the complex lesion, I think we have all the device we can have. The unity is strength. Thank you.
Is there any questions or comments for Professor Lee?
I have one question for you. For the case with severe calcified lesion, you prefer to use the DES, but the radial force of the DES is less than the superior stent. Why you not consider the superior stent? And another reason is drug absorption of the very severe calcified lesion is not good when compared with the less calcified lesion.
Yes, there's two questions. The first one is superior data is very, very good. But how to incorporate this idea into the current guideline? Currently, we want the drug-based therapy. Of course, we can have another idea. Can we use the drug first and then use the superior? This is another idea. The second thing is, yes, you are right. When we are treating the severe calcified lesion, what is the drug efficacy in this patient? So from this perspective, to use the cover stent, I think is the best choice because you don't need to consider any so-called drug-based therapy. You just need to consider from the ostium and the distal. You don't need to consider all the part of the calcified lesion.
I have a short question. You say the drug to drug is a very good idea. So drug first or Viabond first?
This is a very, very good question for this one. Currently, we don't have any good data to compare each other. So this is my only personal opinion. I use cover stent first and then use the DCB to cover the lesion. This is my personal opinion, but we don't have any data currently.
Officially, but for this so long, severely calcified lesions, in my opinion, I think it should be device to device. Is there any device? Is the DES, cover stains, or Supera, but not just DCB alone. Some segment. And in your follow-up is any that because in some segment you just treat it with DCB, the recoil or restenosis may jeopardize the patency of the other part of the stent, the devices.
Yes. So if the age is dissection, we can do the normal to normal. So for the age, we can use not only DCB. Of course, we can use the DS to cover the lesion. So the outcome will be much better with only use the DCB, because the DCB cannot overcome the diffuse atherosclerosis or the dissection or the recoil.
Any question?
A question as the audience. I mean, this 3 case was very complex calcification, total occlusion, and the result was perfect. And my question is that since if the patient has no this long calcification, maybe dissection or diffuse lesion, and after balloon dilatation, there's no after the balloon dilatation is no receive. Is rota first. I mean, maybe this time past the lesion, next time rota, debulking, leave nothing, or just one-time procedure covers that. I think maybe by patient risk factor. I don't know, Dr. Choi.
My opinion, if the patient is claudication, I'll leave the patient with one chance, leave nothing behind if possible. For the patient I just presented, most of the case is a COTI patient, so I need to treat immediately and promptly for the flow into the distal part.
Yeah, I think the indication is very important. Is there one more question?
Okay, the last question.
Last question.
Before you put the stent graft, you routinely prep the vessel with the scoring balloon or normal balloon because of the problem. I concern about the recoil and not fully expansion or not good expansion of the stent graft.
Always high pressure balloon. I learned from Ida sensei. Ida says that you need to use, if the vessel is 6, you need to use 7 like this to crack. It's called a pave and crack. Crack and pave. Crack and pave. I think the idea is very good. Once finally you end this procedure with the cover stent, so you need to do with the vessel size as large as possible.
Okay. Thank you very much, Professor Lee. So we just come back to the room 1. It seems ready to show us the final result. Double? Dr. Choi?
Can you hear? Yeah.
We can see you.
Angels. Yeah, Angel.
Okay.
We
Dr.
use, after we retrieve a filter and we do a impact, you use a DCB impact, 6 by 120 millimeter for 3 minutes. And the next is angio, final angio here. And we check downstream flow, popliteal, and the broad knee vessel. There's no debris dislodge
no
embolization.
Yeah.
Yeah, it's a run of poor foot. Yeah. So,
And we
we
retrieved the filter and we found a lot of debris and
还可以照一下这个可以吗？
Yeah, we can see it. That's amazing. Yeah.
Okay, also from filter.
so I think we will finish this procedure without any big complication. So I'd like to thank to my sincere thank to Dr. Xie and Dr. Lee and Dr. Yang. Dr. Yang can speak Korean very well, so it is very helpful for me.
Very helpful.
So and also I'd like to thank you, Dr.
Chen.
Dr. Chen, commentator. I was commentator. Yeah.
Okay, it's a very good case, and a very very nice nice work, and also the very good result. Thank you very much. Congratulations.
Okay, thank you. Bye.
可以回到 Room 2。
Yeah. Okay.
Dr. Wu, can you
Hi, hello.
tell us that
Yeah.
what's right now?
Yeah, since the proximal entry point is maybe some subminimal, so I try to, I at the first I use through and I snare the Y and use through and introduce the kinetic caster, and then I introduce another Y from the stem, from upper part. Unfortunately, I found that the stump is the internal iliac vein. So we can reach another with another Y. so I dilate the vessel, and we can see the IVUS 看一下. So my plan is to place them to the internal iliac and cover the old stem.
Okay.
You see that 2Y right now? Yeah. And at first I dilate the stem with the 12 millimeter balloon.
12 millimeter.
Yeah, 12. Yeah, 12. Yeah. So 你要放 leg 嘛，对。leg. Yeah. So the next step we will deploy Y-band or leg.
So you will use cover stem.
What do you think about the leg? Yeah, I think cover stem is now a good choice. Even if thrombosis, we can easily treat.
Okay.
Easily pass with Y and so do the thrombolysis. So you can see the IVUS, right?
Yeah, we can see.
Yeah.
This is the IVUS. Just pull back from the right side crossover. And then the IVUS pull back from the left femoral vein. I think left femoral vein here. The size here is 10 by 12. And then compared to the total cushion part here, this is a CDO part here. And we can see the Y is still inside the stem. This is a proximal part of the stem.
Yeah, this is not at all. This is not at all. No. 这许哈。再来吧，你是多少？12十四。
Dr. Wu, so the IVUS confirm that right now the Y is in the true.
Yeah, right now it's in the true lumen, yes. And we go to the internal iliac.
Yeah.
So we decide to compress with we just put a stent, cover stent to internal iliac and cover the previous stent. And the upper part of the stent is patent, so we don't have to cover too long to the IVC.
Okay.
So what do you think about is use the legs or use Y-band?
The size of the
think
previous
Y-band?
stents. The size of the previous stents is.
The case was done in this hospital, so we don't have the data. I think it's maybe 12 or 14. I think it's 12 or 14. Yeah.
12 or 14.
So yeah. So Y-band is another choice. Y-band we have to use the large 30 minutes, the millimeter. Yeah. And Y-band.
Because the Y-band, the certainly maybe not big enough for the proximal end. So maybe like 16.
16.
Yeah.
The
legs means the excluded leg. Yeah, it's for outing aneurysm.
So Y-band. So you think Y-band is okay? So we put a Y-band to cover but to not cover too much. There is a bifurcation. So we just landing just a little bit protrudes to the internal iliac, and I think we can drain all the, or you sacrifice. I think all sacrifice the internal part is okay, right?
Or you can make sure the stent size with IVUS.
IVUS 可以看一下 IVUS 它，就OK， we check IVUS 它 stent 原来大小多少 ？stent 大小 14.
Yeah, the previous IVUS the stent size is 14.
可是我这样看不清楚它大小在哪，我要从另外一个角度找，你看。哦，
不是看直接进那边就好。
他回来叫他。What do you think the landing zone? You think the cover the internal is okay?
Dry seal.
Dry seal. That's dry seal.
Okay.
刚好拿回
You think cover it or just protrude a little bit?
上面。
你说从身上。What do you think about this?
上面
this landing part?
整个上，我差一点点。可以再回来
差一点，
回来1公分，那刚好一只
啊，一只不大够，一只可以。
OK， 这边刚好
在这。Maybe here.
Okay.
OK.
Maybe here.
刚好凸进去了。
Yeah, we just protrude a little bit. 给你放，拜拜。
要不然再打个角度再处理。
OK， 好。I think you have to confirm with another angle, OK？ 这样看到吗？这样好。
因为它这样绕下去，对。
OK。
另外可以把 internal 跟它分开啊。
那另外一边啊，刚。So we did double confirm, okay? Okay, 这 okay. So we decide to deploy here.
Okay.
你放了，
把它回来。
你放了。Okay. Okay, good.
Okay.
Yeah.
那12法律再讲。
先好，这边来，打回 PAP 好，谢谢。Okay. So I think I'm very lucky. I puncture with the wrench and finally passed the stent, and then we have the chance to use the crossover.
128 1的比较好推啊。12 80啊，128。
So after standing, we decide to do the balloon dilatation. 我现在没有照，对不对？我现在stent应该照不出来，我要crossover照。
Dr. Wu, I'll come back to you later. We still have one more lecture.
Okay, sure.
Okay. So we invited Professor Sun to deliver the next lectures about the pelvic congestion syndrome. That because we have the live case in the next section. And Dr. Sun is a cardiovascular surgeon from Mackay General Hospital, and he is the current president of the Taiwan Society for Vascular Surgery.
Okay, good morning, ladies and gentlemen. And the two lab demo cases is very interesting and actually very stressful. And the Professor Lee and my good friend give us a very good talk about the severe case by lesion treated with cover stent. And today, please give me a break. And I just give a very relaxed topics about the pelvic congestion. I'm Sun Sen from Mackay Memorial Hospital. and I'm a cardiovascular surgeon. Treatment about of the pelvic congestion syndrome is really very wide and very complex spectrum, and with many details. So today I would like to just keep the short talk very light and just focus on share briefly our experience about the approach to a PCS and the condition that usually overlooks and with highly treatable when we can understand the venous anatomy. And in the past, many of these patients has pain, but no clear causes, no clear diagnosis, so we cannot treat it very effectively. But right now, with a lot of advance in venous imaging and the intervention, I believe we can do something for these patients. Okay, important risk factor including for the PCS including the multiparity and the varicose vein, and the starting point to the venous origin. And the pelvic congestion actually influence about 15 women during the childbearing age, like age 20 to 15 years old. And about 1/4 of women, when they visited the gynecologist OBD for the pelvic pain, that is caused by the venous problem. So I think the incidence is very high. The pathophysiology is multifactorial. Hormone and reflux and obstruction finally resulted in the venous hypertension. That may be caused some neuropeptides problem and the emotional disorder. I think the most important symptom is pain, but the pain have some character, like the pain should persist for over 6 months, non-cyclic or not related to the menstruation. And this can be aggravated by the long standing and the sitting, especially after a long work or over the day. The pain will become more severe in the evening after long all-day work. And sometimes the symptom may be accompanied by the leg swelling. We call it the extrapelvic symptom sign. And sometimes this problem may be caused by the nutcracker phenomenon. So the proteinuria and the hematuria may be present too. I think the venous plexus all over the pelvic cavity is very complex. But for us, we want to do the intervention for the pelvic congestion. We should be very familiar with all of that. In the past, it is very difficult to clarify what vessel we need to do. But right now in our hospital, we introduce into the SVP system. That means we can combine to clarify the diagnosis and the interventional plan by symptom, varices, and the pathophysiology. One of the pathophysiology is so-called nutcracker syndrome, caused by the external compression of the left renal vein by SMA and the aorta. That may cause the left renal vein of venous hypertension. And as we know, the left side gonadal vein are connected to the left renal vein. So accordingly, the gonadal vein is hypertensive. So that may cause the varices around the and through the, we call the ovarian uterine plexus, and the pressure can downshift to the pelvic floor and cause discomfort. Like this, we can show the varices is very prominent over the left kidney and the proximal ovarian vein with reflux. It accounts for 10% of the origin of all the pelvic congestion syndrome. And this is the most critical issue here is when should we place the venous stent here? I suggest just, and according to a guideline, just stent if the patient is symptomatic, very severe symptomatic. Why? Because the risk of migration of the stent is very high, especially for the Asian population. Because the left renal vein is very short, most of the patients shorter than 5 centimeters. And I think the migration rate may up to 7 to 11%. The data is according to my good friend, Human Jelly. They always allow us not to overstent for the left renal vein. And some doctors like to judge when to place a stent by the CT or MRI, but this is very easier subjected to overdiagnosis. So I think the IVUS with the venography is more gold standard for us. So if no related stenosis, symptom the sign, or I'm not sure this is really a symptomatic the patient, I prefer observe. Because sometimes, but if we leave the left renal vein external compression alone without any treatment, the risk we should bear is that the nutcracker syndrome may be recur or occur. The reason is initially we can find that the external compression with the reflux from the ovarian vein. I think the thing we can do is absolutely correct is do the embolization or scleroscopy for the ovarian vein like this. But for the patient with a severe external compression, the hypertension initially can be released by the reflux from the ovarian vein. But if you only treated the ovarian vein, that may result the more hypertension over the left renal vein. This may cause the frequent pain come back again. So this is the risk we need to bear and pay attention to that after the initial treatment only with ovarian vein embolization. Okay, the second very frequent cause of the venous hypertension over the pelvic cavity is Meissner syndrome. I think many specialists already discussed about it, so I don't want to mention here. Another extra pelvic symptom sign is the varicose vein, and we usually call it the atypical origin. And I think it's very important and easily can be detected by the interventionist or the surgeon familiar with the varicose vein treatment. And we can show here, this is a very typical grade 7 vein reflux. But when you focus on the pelvic congestion, you can see there is some typical varicose vein, maybe from the vulva or the medulla, and sometimes from the posterior aspect of the hip. And this is totally the hint for us to think about the pelvic congestion. And the PIGO is a very important escape point for us, especially we found a very strange varicose vein over the perineal, inguinal, and gluteal and obturator area. And that can give us some hint about the reflux and can give us some hint which vein we need to treat. Like this, but this is too complex, so I don't want to discuss more about it here. And most of the cases in our clinic, in our vascular center, which we initially find that there is a vascular with the ultrasound. We can find the non-phasic venous flow. That means the venous hypertension above the inguinal ligament. And sometimes we can find thrombosis, and almost they have the valve reflux. And I think the gold standard for the initial diagnosis is transvaginal stoma. And we always do it with a reverse Trendelenburg position to make the pelvic venous hypertension more, to increase the venous pressure. And about the sonal finding, I think there's no gold standard, but for us, we always use Spallo, ovarian band larger than 6 millimeter, per uterine band larger than 4 millimeter, and the flow rate is lower than 3 centimeter per second. And sometimes we can find thrombosis and the non-basic flow. And before we want to do the intervention, we still prefer to do a CT venography or MR venography because this intervention is not reimbursed in Taiwan by the public insurance. So for me, I need to calculate the total expense for the patient before the surgery. So for me, before to do the intervention, I think contrast venography plus IVUS is the most important to give us a real time and very precise information to give us to help us to make a good intervention plan. And before the intervention, we always patient-oriented assessment to do something to help us to make a correct decision to do the intervention. For us, we do a lot of questionnaire by our patient care manager, like the VAS, about the pain, and the PVCs for the severity of the pelvic venous hypertension. And we do the PVVQ and the other questionnaire for the life quality evaluation. This is very time consuming, so we need to build a team to collect the data after and before the intervention frequently. So always keep in mind, the diagnosis tool is controversial right now for the PCS, and the etiology is very complex, and the symptom signs are very diverse. So we should make a plan individualized for each patient. Treatment goal is to decrease the pelvic venous pressure, lessen the inflammation, and sometimes we need to treat the mental problem, because I think over 99% of patients is female, and as you know, when they complain about the pain, I think more they will complain her life, her husband, her son. So you need to build a team, and I think the team member should be a mother. It's better for you because they know each other, they know the language, so they can help you to solve the problem of some mental problem. And cosmetics. Okay, how to decrease the venous pelvic pressure? We have a lot of strategy like release stenosis, like NTS-PDS or nutcracker syndrome. We can use a standing or PD alone. Stop reflux, we can do embolization or sclerotherapy. And we can decrease venous volume like sclerotherapy, MPFF, and our good friend is diuretics. And sometimes we need to decrease artery flow caused by the woman hormone. So sometimes we need to use the progesterone to lower the artery inflow. About how to lessen inflammation, I think NSAID and the MPFF is a good friend for us. About the mental, we can give them some sedative and give them the phone number of our patient care manager. About the cosmetics, we can do laser or sclerotherapy phlebectomy, like how we treat the varicose vein. Okay, this is the mechanism with the medication, and the MPFF is good with a good result. And the newest paper published by my wife, he is a gynecologist, and it shows the data not only cure the release the pain, but also it can actually lower the diameter of the vein dilator inside the pelvis. And how about when to take effect by the MPFF? most of the cases and most of the symptoms can be released by 2 months. If there is no improvement, that means this is not maybe caused by the pelvic congestion. So this is not only the treatment, but sometimes for us, if it is very difficult to differentiate, I prefer to use the diaphragm as a diagnosis tool. Surgery, I think in the past, surgery is the first priority, but right now we can do more endovascular intervention because we have a lot of more and more weapon to treat that. You should be familiar with all kinds of weapon. You can do it for the venous intervention. And venous embolization is a little bit different from arterial embolization because the blood flow is back to the heart with a larger diameter. So good anchor is best policy because I think the safety is most important, or maybe the coil and the plug will go back, and finally the destination is the heart, and it's very catastrophe for you to retrieve it. So proper size and proper location, proper landing length is very important, and avoid dislodgement. And another issue is avoid overembolization because we can know this is venous hypertension to cause maybe mass effect to compress out surrounding tissue. But if you put two more coil over there, you will change the condition from temporary compression to permanent compression. That will cause severe pain, and it is very catastrophic for you to retrieve this over-imprinted coil. And sometimes we use the onyx for if the coil is very difficult. It's very difficult and very dangerous for the migration. We prefer use the onyx to be a good alternative because it's more easy to control. And before we jump, we need to know embolize is just to stop reflux, not put all the coil inside the vessel. And don't create a permanent compression. It is very important, or the patient will come back and back for you. And this is a example. At one of my cases, the patient come for pain swelling of the leg and the vulva and the pigmentation with the legs. Echo show normal DVT, venous flow, and the normal Grasseman's vein, Steven's vein. And the PRG show normal venous flow pattern. And according to the typical origin varicose vein, we can find the eye, that means inguinal escape point, especially when the escape point over the left side eye point, that can rise in the concern of the oral vein reflux. And the CT confirmed not critical with the oral vein engorge and a large varices over the left side. And we do the Baru occluded and the venography, and then apply the foam scleroscopy mixed with some contrast. And then I prefer sandwich embolization to avoid over embolization, because as we know, the oral vein have 2 or 3 venous valve in normal patients, so we just place the coil in the original we suspected the location of the venous valve, and then slice with IVUS. So don't put the venous stent inside not so severe compressed renal vein. What is severe? This IVUS can show you almost totally compressed renal vein. Not yet, not yet, not yet. Here, this is a totally compressed renal vein. Please don't put not so severe compressed vein, because one of my students don't keep my secret, so the stent go into the heart, and this is very terrible. And then we place the stent according to the IVUS, and place the Renovent with Venovo 12 and 14 millimeter. After that, we can find there's no reflux, and the flow is quite good, and the collateral disappear. And finally, we do some bottom-up treatment from lower to up with some control from scleroscopy. And the patient had good result. And until now, the patient follow-up at our outpatient about 6 years. And I think the second case is more complex. Maybe share with you that next time. Okay, let's jump to the conclusion. If we want to do the pelvic congestion, accurate diagnosis is very important. And always keep in mind, we have multiple disciplinary treatment. And finally, we can do a precision intervention. And if you want to jump inside, build your team, or you will be crazy for the complaint from your patients. Thank you very much.
Thank you, Professor Sung, for your comprehensive review of this topic. I think this team is very important, and I believe you have got a very good team at home.
Yeah,
and because of
with my
time,
wife.
thank you very much.
Yeah,
and
thank
we
you.
go back to the room 2. Dr. Wu, can you show us the final result?
Yeah. Okay. Then let's go to the previous. Okay. Finally, we put a wire band 13 by 100, and did a post-application. And we can see the final. It's quite good.
它 press 在哪一个？
放在心里。Okay, you see that?
Oh.
And IVUS
nice.
is whatever.
All the correlations are
IVUS
gone.
is, yeah, IVUS is so okay. And we have to very concern the proximal part of the IVC. The previous stent is still patent. The wire band did not cover more, so I think it's good, very quite good. And once if the wire band is occluded, I think it's easily to do the symbiosis from the contralateral. Okay, I think maybe long term we need to long term follow the case, but I think we have another way to treat it once the stent occlusion. Okay.
Okay.
And the wire band, we know the stent age stenosis is a problem. So, but the stent is larger, I think the issue will be less, but not so significant. Okay. So, how do you think about this case?
Yes, very nice. Is there any comments from the panelists? Yep.
好了，结束了。还要看吗？孙生
有听到吗？哦，
哎
非常恭喜点哥啊，我孙生啊
理事长，。谢谢
Yeah.
理事长。
Yes.
好久不见。
I just want to discuss about before the intervention because I just want to know the duration between the first intervention to the occlusion because it is very meaningful. We need to do the course of
10
the
years.
because we
10
need
years
to
about.
we need to know the causes of the thrombosis, and we try to avoid that, or the thrombosis will recur again. And as we know, and according to my good friend Human Jelly, he always pay attention to the inflow evaluation. And according to the venography, this is a type 4, maybe type 4B inflow. And all we know, we have another evaluation for the inflow. That is we can evaluate the size of a common ileal vein, because some patient without good, very superficial or deep movement, but with abundant collateral from below. And for this patient, I think the flow maybe, although this is type 4 inflow, but with good collateral, so inflow may be good. But so we need to still want to try to find the causes of the thrombosis, because maybe sometimes it's not from the structural anatomy problem, but hypercoagulability status. And this can be managed by change to Coumadin or other more strong anticoagulation therapies. Thank you very much.
A very good comment. Okay, I think
maybe long-term follow is needed, but the patient lost follow-up maybe.
Yeah,
The previous stent was done by 10 years. Okay, so it's a 10 years occlusion. I think it's very longer occlusion, and we don't know why. We don't know how. But I think the choice of this standing to this point is good. It's quite good because there's a large corridor, and after standing, you can see that all the vessel was go from the stent, and internal iliac past the stent, then and the deep vein was not solved. So I think it's really caused the compression from the venous subtension. So maybe the next work, maybe we need to Dr. Yen's help, yeah, to closely follow the patient. Okay.
I think that a close follow-up, surveillance follow-up is very important. So thank you very much for the excellent work, showing such good techniques for recanalize.
Thank you.
Thank you very much.
Thank you. Thank you.
I would like to thank all operators and our panelists, and also all the audience. Thank you very much.